PKD. This is a genetic disorder. There are two forms. There's a dominant and a recessive form. Most common form is the dominant form. Dominant. So 90% of the cases are dominant. In dominant, the patient has the gene, but they don't manifest the disease until they are in their 30s. So let's say if Fernando is afflicted with PKD, he'll be born normal. He'll be fine. He'll be in nursing school. No, married. You're married?
Yes.
Yeah, kids. Okay.
Yes.
And then when he hits his 30s, then he'll start manifesting signs of, well, initially it'll be CKD, mild stage 1 of CKD, because his kidneys now start growing cysts.
Okay.
That's why this is called polycystic kidney disease. So cysts will grow all over one or both of his kidneys. Usually, it's both. The patient's kidneys will therefore fail eventually. And these are the manifestations, because now let me see if we have a picture. No picture. Okay, so here's PKD. PKD. So this is what his kidneys will look like. Okay, they'll be overrun with cysts.
Oh.
Okay, and then the cysts, of course, will rupture. There'll be some bleeding. Okay, there'll be blood in his urine. This is painful too. Patient will have, and the kidneys will enlarge, so the kidneys become palpable. This can also obstruct bowel movements. Patient may have constipation as a result. So here are your manifestations. So the patient will have CKD, and the size of the kidneys, as already mentioned, they get bigger. So the kidneys become palpable when normally they should not be. There's blood in the urine. There's hypertension, sign of CKD. There'll be also stones, and then the patient will also have UTIs, and then proteins will start leaking into his urines. Okay. And then this will only get worse. Okay. So after diagnosis, his condition will progress from stage 1 to now stage 2, and then eventually Fernando will have end-stage renal disease. Okay, so he'll need to go on dialysis eventually. It's genetic. So just like any other genetic disorder, can you do something about it? Okay, so the only way will be to stop having biologic children. Okay, or if you can afford it, you can do gene editing, let's say, or also embryonic choosing embryos. So we'll do in vitro fertilization, and then we'll choose the embryos that don't have the gene, then those we will implant. Okay, that's the only way if you can afford it. Okay, so you need a lot of money to prolong your bloodline. All right, I mean, it's up to you, however you want to approach this. So genetic counseling, just like any other genetic disorder, genetic counseling will be included because there is no cure. Tolvaptan is a drug we use to increase sodium levels. If you remember, this drug was, there was no drug therapy mentioned in SIADH. But yes, one of the drugs used in SIADH to increase sodium levels was tolvaptan. So this can be used, okay, to just slow down the progression of the disease. Again, there's no cure. Okay, so you can slow it down. That's all you can do. Side effects of tolvaptan, of course, is polyuria. Then again, this will raise your sodium levels as well. And as already mentioned, once his kidneys are overrun with the cyst, then Fernando will have to go on dialysis. Sad, yeah? And that's it. That's all we have for PKD. Any questions? Yes. Rare though, which is, although my my best friend in college, his wife turned out had PKD. So, we were, good buddies, and then he met his wife sometime in early 2000 and got married. And it was, yeah, no problem. They had kids, and then just one day she manifested, her blood pressure was sky high. She wasn't feeling good. She was having palpitations. So she was having hyperkalemia already, signs of kidney failure, hyperkalemia, and then BN creatinine was high, and then she, had high blood pressure. So they worked her up, and then the ultrasound showed, I mean, the CAT scan showed enlarged cystic kidneys. She didn't know, meaning it didn't manifest in her parents, but probably in her grandparents had them. Yeah. Okay, let's go to the next chapter. Because for chapter 48, that's all we have. But for 49, let's start with UTIs. This will go quickly because you already did UTIs in MedSurg 1. Okay. So UTIs, this is the technical term. We have cystitis, prostatitis, or urethritis interchangeably, but urethritis usually is from STDs. Whereas prostatitis, of course, this is for the prostate gland. And for our UTIs would, of course, be cystitis. Risk factors: females, diabetes, pregnancy, neurologic disorders. When we say neurologic disorders, these are people who either had a stroke or some other neurologic conditions that affects bladder contraction, meaning your bladder can't contract normally. So what happens to urine output? Decrease, right? You have urinary retention, and then urinary retention always leads to UTIs. Gout, invasive procedures, okay, or any of these other causes. So stones, also obstruction. Again, whenever you prevent urine from coming out, then that can usually lead to UTIs or infections. Meaning basically you allow the bacteria to grow. For the elderly, since they have here the number one risk factor, okay, so the pH, especially in the female, changes, right, as you grow old. Then for elderly also, they become incontinent. So that will, again, increase bacterial growth in the perineal area, especially if they're not cared for right away after the bowel or bladder incontinence. Let's go straight to signs and symptoms. So you have urinary frequency, nocturia, urgency, lower abdominal pain. There could also be suprapubic, which is lower abdominal, or pelvic pain. Could also be flank pain especially if the kidneys are already affected. Hematuria also can be present. Now, UTIs can enter the bloodstream and become urosepsis, and that can be deadly. So untreated UTIs can enter the bloodstream. It can also swim up the ureters and infect the kidneys, in which case you have pyelonephritis, which always predisposes you to sepsis as well. For the elderly, here are what increases the UTI frequency in the elderly. I won't read it for you. Please read them. You would select all the apply question. These are the common organisms. E. coli is the most common, from contamination, especially if the patient does not perform hygiene or if the patient is incontinent. The other infectious organisms are usually from facilities. If the patient is hospitalized or institutionalized, then these are the organisms that you'll find. How do we diagnose it? Well, we need a urinalysis and a urine culture. Treatment. Antibiotics. There's two types of general types of UTIs. Either simple, uncomplicated UTI, or you can have a complicated UTI. If it's uncomplicated, usually short course, 3-day regimens, or 3 to 7 day regimens. But for complicated UTIs, it could be 10 days to 2 weeks, okay, depending on the causative organism. If it's a highly resistant organism, then the antibiotic may be the antibiotic course may be longer. Table 49-1 does not have the details for the drug, meaning they don't have nursing responsibilities. All it does is the indication. So that's all I'm testing. Table 49-1, these are your most common antibiotics used to treat UTIs. Please take note that the last one, phenazopyridine, is not an antibiotic. Okay, it's only a urinary analgesic. This is only going to treat the symptoms. UTIs, patients with UTIs usually complain of dysuria, meaning burning upon urination, and pelvic pain. So phenazopyridine will be used. One common side effect of pyridium or phenazopyridine is what? What does it do to the urine color?
Orange.
Okay, it stains it orange. Yeah, but again, the patients, all others are antibiotics. So you got Bactrim, nitrofurantoin, okay, and fluoroquinolones as well. So these are for UTIs. But pyridium or phenazopyridine is not an antibiotic. Are we clear? Okay. Okay, let's go now to CAUTI. Oh, sorry. Let's finish the supportive therapy. So patients with UTIs are encouraged to increase urinary output increase fluid intake unless otherwise contraindicated. So this will help flush the organisms out. Avoid these beverages, namely coffee, tea, citrus, spices, or colas and alcohol. And then also, besides water, cranberry juice can be taken. Okay, so cranberry juice is part of the acid ash diet. This will acidify the urine, preventing bacterial growth. Okay, you can also take cranberry supplements. They are available in tablets. Take tablets or capsules? Does anybody here take cranberry supplements? As already mentioned, UTIs can lead to urosepsis, and that can be fatal. And here's your teachings to prevent UTIs. Hygiene before and after intercourse, and also before, especially females, before and after a bowel movement. Okay. Increase fluid intake. Do not hold urine. Okay, stop holding your bladder too long, okay, because that can promote bacterial growth. And for medications, finish your antibiotic course. Take cranberry juice or capsule. It is capsules. Okay. Urine test kits are available over the counter. You can take those if you don't want to go to the ER or the urgent care clinic. You can test it yourself, and then if it's positive, then you can go to a provider. CAUTIs. What are CAUTIs? Catheter associated Urinary tract infection. Okay. So these are never event. So never events, do they get reimbursement? No. So this is serious. Therefore, patients with catheters, should they really be in place? Well, depends, right? So what did we discuss? We did this last week. What are those 4 indications for a urinary catheter? Meaning it'll justify. Okay, surgical patients. What else? Is incontinence a indication?
Incontinence.
What else? So surgery. Okay, so a pelvic wound, okay, or pelvic or perineal wound. What else? Meaning chronic wounds. Okay, yeah. And then acute or chronic urinary retention. And then finally, what's the 4th one? Hemodynamically unstable patients. Okay, so wherein we need to monitor hourly urine output. So unless your patient's reason falls under those 4, then should they have a catheter? No. Because once they develop a UTI from that catheter, what happens to the cost? Okay, no reimbursement. So the hospital bears the cost of that treatment. Let's talk about the bundle. So let's say the patient meets those 4 criteria, and then now they have a catheter. So what should we do? Now they have a catheter. How do we decrease the incidence of a CA UTI, of a COTI? Perineal care. And where should the bag be placed? Okay, below the bladder. Should the bag be labeled? Okay, should the catheter be secured to the thigh? Okay, should there be perineal hygiene after every bowel movement? Yes. Okay, and then also every shift. Okay, catheter care every shift. Can the patient shower? If possible, yeah. If they're ambulatory, yes. Go ahead and please shower. Okay, shower, soap and water. That's great. Okay, so to clean the perineum. Okay, if running water is best. All right, that's it for UTIs. Let's go straight to the next. All right, pyelonephritis. So let's say the UTI got out of control, escaped local control. Now it's in the kidneys now. Now we call it pyelonephritis. Now there's 2 types here. We have acute and chronic pyelonephritis. Acute pyelonephritis, these are the manifestations. And then we'll compare it to the chronic. Okay, so what do you see under acute pyelonephritis? What do you see? What do you notice? So what are these signs and symptoms of? Yeah, what are these manifestations of? A UTI. Very good. So therefore, what causes acute pyelonephritis? A UTI. Okay, an untreated or undertreated UTI. Whereas if you go to chronic, I'll come back here. Here, look at because it's a UTI, and then now it affected the kidney. So what's the treatment? Do we treat the UTI? Yes, so same antibiotics, right? Unless the patient has manifestations of sepsis, then we'll add even more antibiotics. Okay, so 2-week course of antibiotics for acute pyelonephritis. And of course, the non-pharmacologic intervention also, everything we did, hygiene, cranberry tablets, increasing fluids and frequent voiding, right? And proper perineal care. With chronic, look at the manifestations of chronic. What do you see?
No symptoms. infection. Acute sepsis.
So what are these manifestations of? Does the patient look sick? Are these signs of an infection? No, these are not manifestations of an infection, is it? No, these are infections, right? These here, these are manifestations of an infection. So therefore, chronic pyelonephritis, do they manifest manifestations of an infection? No. What causes chronic pyelonephritis, therefore? Repeated bouts of acute pyelonephritis can lead to chronic pyelonephritis. Are we clear? But if you go to acute pyelonephritis, what causes it? A UTI, usually, okay? So 9 out of 10, this is caused by a UTI. Meaning the patient had no idea that they had a UTI. We found out the UTI is already up to the kidneys. Okay, it already caused pyelonephritis. So if it's chronic pyelonephritis, well, depends on the cause. If we see bacteria, then we will treat them with antibiotics. If not, we will treat the patient just like we do with chronic kidney disease. That's it. Let's go to finish everything. Um, okay, let's look at here for catheters. So here's your COTI bundle. Aseptic technique. Again, we mentioned this, right? So we secure the catheter, we perform daily care, and also after every bowel movement. Oh, we forgot this one. Discontinue as soon as possible. So in your daily assessment, you will be asked when you document on your COTI bundle. The last question is it still clinically necessary? And there's only a yes or no question. If your answer is no, then what do? It must be discontinued. Okay, meaning this is the nurse's judgment now. Okay, so the last question will be if you answer yes, clinically necessary, then you have to document the reason. Why is it still clinically necessary? What's your reason? Then you choose from one of the following reasons. But if it's no, then what should you do? Discontinue. So ask for an order to discontinue. You can initiate it. You don't have to wait for the doctor. You can tell the doctor, can I take this out? Right? So be a patient advocate, right? Catheter should not be in there unless absolutely necessary. You know about suprapubic catheters? Okay, so this one is for long term. So an option is take it out of the urethra because is it comfortable to have a catheter hanging out between your legs? Especially in the male, something hanging out of your penis. No, right? So now an option is if the patient really needs long-term catheter, then they'll put in a suprapubic catheter. Here it is. They put it above the symphysis pubis. So this is the bladder. So what they'll do is create an incision. So it's like a feeding tube. Okay, so a feeding tube, a peg tube is in the stomach, right? So this one is in the bladder. Okay, so you have a catheter in your bladder. This can stay forever. They can change the catheter periodically, which is required because the catheter, of course, gets dirty and increases infection. So they can change it. So they'll take it out and then insert a new catheter periodically. Same thing. So do you still do catheter care here? Yes, same thing. So instead of cleaning the penis or the urethral opening in the by the vagina, then you'll do your catheter care over here. Okay, so same thing. Oh, we have a chart for Coty bundle. Chart 49-9. Now the standard on, have you heard of um core measures, Joint Commission core measures? It's okay if you haven't. Okay. So one of the uh, s- Joint Commission core measures to prevent UTIs is a catheter. If the patient has a catheter, remember those four indications, no, four reasons why you can have a catheter. The limit, according to Joint Commission, is 48 hours. Used to be 3 days, but now they cut it down to 48 hours, meaning you have to take it out as soon as possible. If possible, it should not go beyond 48 hours because data and evidence suggest that an infection, a UTI, starts growing if it stays longer than 48 hours. So the standard, therefore, is take it out after 48 hours. Meaning, what are those four indications again? One is surgery, right? So if it was used for surgery, so how long after surgery should you take it out? 48 hours after surgery. If they're hemodynamically unstable, okay, so hopefully 48 hours later, they should be stable already, okay, and then we can take it out. Third, what was the other one? Yeah, the wound. Well, in wounds, then we have no choice because those are, gonna take a while. Then what's the other one? Okay, acute or chronic urinary retention. For if it's acute urinary retention, then find out. Okay, do a trial void. Okay, take it out and then see if the patient can void. That's it. Because the other topics on the blueprint are not in your textbook. So we'll skip that.